So this lecture will just be an introduction to my thought process when going through the neurological examination. There are countless ways to go through this, but the key is to be systematic about it. And again, this is just my way of going through it. There is a video that I posted of me doing the neurologic examination on my own dog as an example of those who are actually interested to see the process of me going through the neurologic examination. For those interested, this book is in my shared folder, and the first two chapters are dedicated to the neurologic examination and also localization. I have additional folders in my shared folder as well, which are the major neurologic topics that we'll try to cover during the rotation. So there's things on seizures, intervertebral disc disease, vestibular disease, and so on. I have also provided a website here that can go through every step of the neurologic examination. There's also videos on what is normal and abnormal for each process. So whenever we do the neurologic examination, the first step is to answer the question, do you think it's neurologic? The second question is, where in the nervous system do you think the problem is? Now, as you watch this video of this patient, I want you to answer those two questions. Of course, it's not always as obvious as this patient, but sometimes, at least if you're comfortable with the basics, it can be fairly straightforward. So before we ever put our hands on a patient, the first thing that we need to do is observation. That is where every exam should start. And to emphasize the importance on observation, we will go through several examples on how to localize a patient just by observing them. With this patient, we know that there's a forebrain localization because this is what a tonic-clonic seizure will look like. There could be other neurologic deficits with this patient, but I know for certain that this patient has a forebrain localization. When we're going through the neurologic examination, we'll start broad. And so the first step that I want you to think about is, could it be intracranial? Could it be something with the spinal cord? Or could it be neurologic? Now, when we're thinking about intracranial localization, I'm not so worried that you know all these names, proencephalon, mesencephalon, and so forth. What's more important to me, especially when we're thinking from a clinical standpoint, is, do you think it's forebrain? Do you think it's the brainstem? Could it be the cerebellum? Or could it be the vestibular system? So there's four areas that I want you to be able to neurolocalize when we're talking about the intracranial region. So as you're watching the patient, think, is it intracranial? And then, if it's intracranial, which of these four areas could it be? When it comes to the spinal cord, there's four areas that I want you to think about as well. C1, C5, C6, T2, T3, L3, and L4, S3. So a simple way to think about it is there's four intracranial areas of localization and four spinal cord areas of localization. Again, whenever we do a neurologic exam, the first thing that you should be doing is observation. So as you're getting a history from the owner, there's things that you should be observing. So there's behavior, the mentation, the posture of the patient, and then also the gait. So we'll go through each of these and just give examples on how changes in behavior, mentation, posture, and gait can help as far as our neurolocalization. So going back to this patient, when you observe them, you can tell that their behavior is not normal. So right away you should be thinking a forebrain lesion. With a patient having the tendency to turn to the left, your localization in this patient should be left forebrain. Now, for those that are more observant, you might notice that there's a hypermetric aspect to the gait in the right thoracic limb. So this patient very well could be multifocal, but I know for certain, just on the observation, that there's a left forebrain lesion. In this patient, you might have noticed that there's a limp. This patient has a head bob. So although there's this pacing and circling, overall the patient is fairly interactive. This patient actually had a cervical lesion and was so painful to turn his head to the left that he just kept turning to the right. The reason for the lameness is associated with nerve root signature. As far as behavior changes that we can think of, there's pacing, circling, aggressiveness, blindness, a patient becoming obsessive. One of the more common things that we might see is a patient can become incontinent, and they can also just be distant to where they stare off and they don't always seem there and they don't always respond like you might think they should. Something else a lot of people will talk about with behavior changes is dullness, but I typically would classify dullness as more of a mentation change. So although this patient's behavior is not normal, there's also a change in the overall mentation. So most of y'all should be thinking that there's a left forebrain lesion. And when you watch this cat, notice he's still breathing and stuck there. So this patient is quite dull, and to a degree, the golden retriever we initially looked at was dull too. As far as mentation, when we're classifying it as an abnormal neurologic mentation, we can classify patients as being obtunded. They can be mild, moderate, or severely obtunded, stuporous, and comatose. The difference between stuporous and comatose is that stuporous patients are still responsive to some sort of noxious stimulus, whether it be a strong smell, a loud sound, a strong light, or actually doing something painful to see if they're responsive. Whereas a comatose patient, such as this cat here in this image, is not responsive to anything. They're still breathing, they still have a heart rate, but that's it. You could argue that an obtunded patient is anything in between stuporous and alert, and that's why some people will use mild, moderate, or severely obtunded. So that's the start of observation. What is their behavior like? What is their mentation like? And the next thing that we can talk about is their posture. So as you look at this patient's overall posture, yes, the gait's not normal, but focusing on the posture at this moment, I want you to think, is it normal? And if it's not normal, what's not normal about it? So you can see how low this patient is being crouched. And that's not normal, especially for a patient that seems as friendly as this. Some cats can fool you in thinking that it's abnormal, but it could be because they're just so scared. The other thing I want you to think and look at is this patient's head posture. Is it normal or abnormal? So again, look how low this patient's posture is. He's got a wide-based stance in the pelvic limbs. And also, if you notice, there is a left-sided head tilt that this patient also has. So just by looking at this patient's posture, you should be thinking about there being a vestibular lesion for this patient. There's other postures too. So this is a patient that has another posture that you can see, as with this kitty cat, is a decerebrate posture. A decerebrate posture is usually indicative of a grave prognosis. And you should be able to localize immediately where this patient's lesion is if you see this kind of a posture. So when you're thinking of postures, as far as helping with localization, think about a head tilt versus a head turn, a decerebellate posture versus a decerebrate posture, and then also shift Sherrington. And a lot of times with decerebellate and decerebrate and even shift Sherrington, they can have opisthotonus. And patients that are painful in their neck will often be neck guarded as well. So those are different postures. And as far as where you might localize, I want you to think about those, but we'll talk about that later. After posture, you want to be thinking about gait. So as this patient walks, I want you to think, is it normal or abnormal? If it's abnormal, could it be neurologic? And then neurologically, what's abnormal about it? So a big key to take away whenever you're watching a patient's gait, if something's abnormal with it, usually you're thinking, could it be orthopedic or could it be neurologic? And a big key in saying is something neurologic is there ataxia? And this patient is severely ataxic, and it's in all the limbs. So if you watch, all the limbs have this long stride to them and a degree of proprioceptive ataxia. This is a patient with a pretty typical C1 to C5 upper motor neuron gait with proprioceptive ataxia in all the limbs. As opposed to this patient, who has a pretty classic C6 to T2 localization, and you can see the different stride lengths between the thoracic limbs and the pelvic limbs. The reason why I like showing this patient so much is when we did the rest of our examination, without seeing this patient's gait, you would have thought it was a T3L3 lesion. So that's why it's so important for patients that are ambulatory to actually get them up and see how they walk. Because right away I can tell you that this patient has a C6 to T2 lesion. The short choppy gait means that there's motor unit disease or lower motor neuron signs to the thoracic limbs, and the longer stride in the pelvic limbs is indicative of an upper motor neuron lesion to the pelvic limbs. Again, looking at gait, as you watch this patient walk around, I want you to think, is he ataxic or not? Is there knuckling over? Is there crossing of the limbs? Is he falling towards one side? And he's not. The patient just has this very crouched posture. He's trying to shift his weight to the thoracic limbs. And eventually, even the thoracic limbs are affected, and the patient has to lie down. Again, watching the gait again, you can see there's no evidence of ataxia. This is a patient who's truly weak and has a motor unit disease. The technician is giving an injection of a medication. This is known as the tensilon test. And you can see after the tensilon has been given, or the edrophonium, The patient is then able to walk, and the gait is normal. So this is consistent with a patient with motor unit disease. The classic for this would be myasthenia gravis. Another reason why observation is so important is because sometimes it's all you're able to do. So if you have a very large animal who's ataxic, it's not safe to do certain things with their examination. But if you just observe this patient and pay attention to the details, you can see that this patient is truly ataxic, that all the limbs are affected. As you watch him come up to this mat, he'll knuckle over. It's also very unsteady with turning. So for this patient, we know that the lesion is going to be C1, C5, or more cranial to that, for all the limbs to be affected and for the patient to be ataxic. As a general rule, patients with upper motor neuron lesions will be ataxic, whereas patients with lower motor neuron lesions will be weak. You could argue that this horse has some degree of paresis, which is common with upper motor neuron disease. But the ataxia is the giveaway here, that this is a central nervous system disease and not a motor unit. So when we're observing the gait again, we're assessing for ataxia. If there is ataxia, we want to know, is it cerebellar? So is there dysmetria present, with the most common form of dysmetria being hypermetria? Is there proprioceptive ataxia? Some people will call it spinal or sensory ataxia, but proprioceptive ataxia is the most proper name for it. If you're noticing a patient knuckling or crossing the limbs, that would be indicative of a proprioceptive ataxia. The final would be vestibular ataxia. So are they falling to one side? Are they rolling? And then also posture, so the position of a head tilt can help you with vestibular localization. Is there weakness or paresis in the patient? Or in the most severe cases, is there complete paralysis, palsy, or plegia? All those three words are meaning the same thing. So there's no movement in that limb at all. So with our neurolocalization, when it comes to observation, we talked about behavior, mentation, posture, and gait. Again, with behavior changes, we're thinking that there's an intracranial lesion. Specifically, we're thinking that there is a forebrain lesion. So as we watch this patient, a normal dog should not get stuck in corners. So this is an abnormal behavior. And once the patient is free from the corner, you can see that he continues to pace. And pacing, this compulsiveness to just wander and wander, is not normal behavior for a dog. Getting stuck in corners is not normal behavior for a dog. And you can see once he's free from corners, the patient will continue to pace. It's hard to localize a side for this patient. It tends to turn to the left more than the right, but it will still turn to the right at times. But we can say that this patient has a forebrain localization. If we did the rest of our exam, we might find that there could be multifocal disease. But just from the observation of this patient, we know that it's forebrain. When we're talking about mentation, we're talking about localization intracranially. More specifically, either forebrain or brainstem. For a patient to have an abnormal mentation from a forebrain lesion, it usually has to be quite large. However, a patient with a forebrain lesion will never be stuporous or comatose. Only patients with brainstem lesions can have that degree of mentation abnormalities. When it comes to posture, depending on the posture seen, will depend on localization. So if we have a patient with decerebrate posture, we're thinking about a brainstem localization. Those patients are usually stuporous or comatose and have severe changes in their cranial nerve examination. For a patient to be decerebellate, as the name implies, it would be localization to the brainstem. The difference between decerebrate and decerebellate is in the pelvic limbs. With decerebrate rigidity, all the limbs have increased tone. Decerebellate, the pelvic limbs should be flexed, but there's still opisthotonus and also increased extensor tone in the thoracic limbs. For a patient to have a head tilt, there's a vestibular localization. Now, we're not going to know if it's central or peripheral, but a head tilt should be a dead giveaway that that patient has a vestibular problem. If we have a patient that has a Schiff-Sherrington posture, it can look very similar to either decerebrate or decerebellate, but we can tell the difference because their mentation, their behavior should be pretty normal. And when you get those patients in a standing position and you check proprioception on them, the thoracic limbs should be normal, whereas the pelvic limbs will be extremely abnormal. A Schiff-Sherrington posture is indicative of a T3-L3 myelopathy, usually a severe myelopathy, but it does not indicate anything as far as prognosis. The reason why a patient with a T3-L3 myelopathy can have a Schiff-Sherrington posture is because there are cells called border cells which live in the L1 to L4 region, and they send projections cranially to the thoracic limbs through what's known as the fasciculus proprius tract. From there, it will cause a synapse on the thoracic limbs, which decrease extensor tone. So if you have loss of the inhibition or disinhibition, you're going to get the overriding feature. So with a T3-L3 myelopathy that's severe, and you lose the input from the border cells, you get hypertonicity of the thoracic limbs. So a patient that has a Schiff-Sherrington posture, immediately you know there's a T3-L3 lesion. As far as the gait, again assessing are they lame or ataxic, is there weakness or is there some degree of paresis, or is there complete paralysis or plegia? So as we watch this patient, this is a patient with vestibular disease. And observe not only the posture but also the gait. So as we let the patient go, you'll notice they start to crouch low, but they're falling to the right, circling to the left, and trying to catch themselves. So this is a pretty common gait for a patient with vestibular disease. They'll drift towards one side, and they can often fall towards that side as well. So as far as the gait localization, it's going to depend on where the lesion is at. But if you have ataxia that's present, defining what type of ataxia is present will be helpful. And if you have weakness versus paresis or paralysis, that can also be helpful too. So that's the observation, behavior, mentation, posture, and gait. The next part is where we actually put our hands on the patient. So we can do postural reactions, segmental spinal cord reflexes, evaluate the cranial nerves, do the cutaneous trunci, and also check for hyperpathia and conscious pain perception. As a quick note, hyperpathia does not help us with neurolocalization. If you have a patient that is painful in the T3L3 region but has signs consistent with a left forebrain lesion, you're going to localize the patient as a left forebrain. The reason the patient could have hyperpathia could be related to a neurologic problem, but it could also be related to something completely different. So patients with polyarthritis can be painful along their back. Patients with a myositis can also often be painful, so it doesn't always have to be related to a meningitis myelitis as well. With conscious pain perception, it also does not help localize. You can have an L4-S3 lesion that causes absent pain perception and a T3L3 lesion that causes the same. However, with conscious pain perception, remember it's probably one of the most important things when we're talking about spinal cord injury in predicting prognosis. So quickly talking about proprioceptive placement. If you watch my video on me doing the neuro exam on my dog, it goes into a little bit more detail as far as the differences between these. But the big takeaway is that proprioception is that awareness of where our limbs are at in space. And these are some of the longest fibers that we have in the body because it's one neuron that goes from the tip of the tail up through the limb, through the back, through the neck, and to the brain for the actual interpretation. And then it sends the signal down to the limb for it to correct itself. Remember that when we're doing proprioceptive placement, we should be supporting a certain percentage of the patient's weight. We knuckle the patient's limb over, and then we should see them correct themselves. So you can see how one side on this patient is much worse than the other, although neither is completely normal. It's also important to note that we know nothing about this patient as far as localization. We can say that this is neurologic and not orthopedic to cause the deficits. Now, since the thoracic limbs are normal, we're thinking that this is either a T3L3 lesion or an L4S3 lesion. But we still need the rest of our examination, so looking at the observation, so behavior, mentation, gait, and posture, and then doing our proprioception to paint the entire picture. When it comes to spinal cord localization, again, we're localizing to 4 areas. The reason we can do that is because the intumescence for the thoracic limbs lives C6 to T2, and the intumescence for the lumbar is L4 to S3. When we're differentiating upper from lower motor neuron, the things that are most important are going to be reflexes, atrophy, and tone. Again, proprioception, pain, and weakness do not help differentiate upper from lower motor neuron lesion. So if we do our reflexes and they are intact or increased, we're thinking upper motor neuron lesions. If we do an examination and you feel that the patient has increased reflexes, but I'm calling them normal, it does not change our localization. With lower motor neuron disease, the reflexes are either decreased or absent. So if you're calling a patient having them decreased or absent reflexes, but I'm saying they're intact or normal, then there is a difference in our localization. For the atrophy, it can be quite severe in either aspect, but it's usually much more severe with lower motor neuron disease, as they will have a neurogenic atrophy, as opposed to a disuse atrophy with upper motor neuron disease. But if the If there's a chronicity to it, especially if it's been months, atrophy can still be quite severe with upper motor neuron disease. When it comes to tone, it will follow the reflexes. So upper motor neuron lesions are usually spastic, or they'll have increased tone, whereas lower motor neuron diseases are usually have decreased tone and can even be flaccid. So if we're thinking that a patient has a C1 to C5 myelopathy, you should be thinking that the behavior is normal, the mutation's normal. Think about the posture. What is their gait like? So they should have a long stride and proprioceptive ataxia in all the limbs. Their proprioceptive placement should be delayed in all the limbs. If it's lateralized, it might be worse on one side compared to the other. Thoracic limb reflexes and pelvic limb reflexes should be increased or normal, along with their tone, and again, depending on the chronicity, there may or may not be atrophy present. Before we go on, I just want to make a note that when we're talking about localization, we're talking about the spinal cord segments, not the vertebra. So, although when we're looking in the thoracic region, the T12 spinal cord segment might live in the region of the T12 vertebra, it doesn't always go that way. And the number of spinal cord segments does not always correlate to the number of vertebrae either, as there's 8 spinal cord segments in the cervical region, but only 7 vertebral bodies. For a C6 to T2 lesion, again behavior mutation, that should be normal. Their posture can depend on the severity of it. So if it's a severe enough lesion, they can be in lateral recumbency. For their gait, as we observed in that patient before, they'll usually have a short choppy gait in the thoracic limbs and a long strided gait in the pelvic limbs. Some people will call this a two-engine gait. For proprioception, the thoracic limbs and the pelvic limbs should both be affected, sometimes the pelvic limbs more so than the thoracic, especially with more caudal C6 to T2 lesions. Thoracic limb reflexes should be decreased, and the pelvic limb should be normal to increase. And again, when we're evaluating things with the cranial or intracranially, it should be normal, except you can get Horner signs with a C6 to T2 lesion. Again, thinking about the track of the sympathetic nerve and how it goes, traveling through the brainstem, through the cervical region of the spinal cord, where it exits, usually around the T1 region. And then from there, when it exits the T1 region, it's part of that brachial plexus, which is why lesions in the C6 to T2 area can cause a Horner syndrome. From there, it travels back up the neck, eventually goes through the middle ear, and then will eventually go to the eye itself. If we have a patient with a T3L3 lesion, they should be normal from the shoulders on up, unless they have a shift-Sherrington posture. So when you put them in lateral recumbency, you can see that hypertonicity of the thoracic limbs. Their gait will depend on the severity, but they can have a proprioceptive ataxia. They can be paretic or, in worse instances, completely plegic. The thoracic limb reflexes should be normal, along with proprioception of the thoracic limbs. And the pelvic reflexes should be normal to increased. With an L4-S3 lesion, it's similar to the T3L3. The difference being is they should not have shift-Sherrington posture. So the thoracic limb should be completely normal, and the reflexes will be decreased to absent, and the tone as well will be decreased to absent. Cranial nerves, just kind of harping on the point, should be normal. So if you have a patient with an abnormal mentation, but you're getting decreased reflexes in the pelvic limbs, then you should be thinking of a multifocal lesion. For the next part, we'll talk about the cranial nerves. And just as a reminder, there are 12 pairs of cranial nerves, and I'm sure all of us have a mnemonic to remember them by. We will tackle the nerves in order by numbering, starting with the olfactory nerve. This is one of the more difficult nerves to assess. When trying to assess, be sure to avoid irritating substances as it can activate nociception of the trigeminal nerve. As a general rule, a dog will not sniff unless they have a scent. So if you hide an object in some way and they start to sniff, you can say that the olfactory nerve is likely working. Generally, we're not assessing this nerve as it clinically is usually not a big concern. Cranial nerve 2 is what we will discuss next, and there are a number of ways to assess vision. Recall that the visual pathway is quite complex, as it begins in the retina, where an object is within the visual field for there to be a conscious perception of what the object is, and then that signal from the retina will travel up the optic nerve, through the optic chiasm, through the optic tracts, where it'll synapse in the thalamus on the lateral geniculate nucleus. Depending on the species will depend on how much crossover is present. Once there in the lateral geniculate nucleus, it'll send up optic radiations to the occipital cortex for there to be perception or consciousness that there is vision. One of the most simplest ways to observe or assess vision is just observing the patient in a room. Putting a patient in a foreign room and seeing how they can navigate obstacles. If they keep bumping into things, especially if it's on one side, you can be pretty certain that there's going to be absent vision or at least severely diminished vision in that eye. Another test that can be done is with tracking, and this can be very useful to assess one eye at a time. So when an object catches a patient's attention, they should look in that general direction. Be sure to use a light object, such as a cotton ball, so that when the object hits the ground, it does not make a sound. The Menace response is a very common way to assess not only vision, but also cranial nerve 7. Recall that this is a response and not a reflex, so it has to be learned, and the majority of dogs and cats will learn to menace by 12 weeks of age. This is a very complex pathway in that it goes through the optic nerve, through the optic chiasm, optic tract, again synapsing on the lateral geniculate nucleus within the thalamus. There it goes to the occipital cortex, then to the frontal cortex, back through the thalamus to the cerebellum, to the facial nucleus, and then through the facial nerve in the middle ear, where it eventually will cause the blink response. So a lesion anywhere along this pathway can cause an absent menace, but the patient might not be blind if there is an absent menace. So we also check to see if the facial nerve is working as well, which is why it's so important to do a complete neurologic examination before just making the localization. When we're evaluating the eye, we can also evaluate the pupils. So remember, when there is evidence of miosis, you might want to think about Horner's, which is a loss of sympathetic tone to the eye. But when we're assessing the pupil size, we need to make sure that there is no anisocoria. When we put a patient into a dim room or a dark room, and when we're shining a light at the bridge of the nose, those are some of the best ways that we can assess for anisocoria. And you can see a quick way or quick example of me doing this on my examination of my dog. When it comes to Horner syndrome, as we talked about earlier, it's loss of sympathetic tone to the eye, and it results in miosis or small pupil, ptosis in ophthalmos, elevation of the third eyelid, and it can also lead to vasodilation. And in the horse as well, you can end up with sweating too. When we're doing the pupillary light reflex, recall that this pathway is going to be different than the visual pathway. It starts out the same with input going from the retina to the optic nerve and then to the optic chiasm, but there is decussation within the optic chiasm and separation from the visual tracts. And the pupillary are the pupillomotor fibers, which go to the pretectal nuclei in the midbrain rather than to the thalamus. There it projects pathways to the parasympathetic nucleus of cranial nerve 3, which crosses over from the pretectal nucleus to both parasympathetic nuclei, at least in mammals. In birds, there is not a double crossover, so the pupils do not respond together from the parasympathetic nucleus of cranial nerve 3. But once the synapse is there on the nucleus of cranial nerve 3, the oculomotor nerve will send the signal to the ciliary ganglion, the autonomic ganglion in the retrobulbar area, and finally cause a constriction to the pupil. Now, when we're there looking at the eyes, this is the time. Another aspect when we're evaluating the eye are the eye movements. What controls the eye movements are going to be the third, fourth cranial nerves, which originate from the midbrain or the mesencephalon, and the sixth nerve, which originates from the myelencephalon or the medulla. Now, animals should have conjugate eye movements, so whenever one eye moves, the other should move together. If they are not moving even, or one eye is looking in a different direction than the other eye, such as in this image, you can see on the image that there is a left ventral lateral strabismus. The strabismus is an abnormal deviation of one eye, or sometimes even both eyes, such as with hydrocephalus. The direction of the strabismus depends on the nerve affected. So, with oculomotor nerve damage, you'll see a ventrolateral strabismus as shown in the picture. With trochlear, there is a rotational strabismus, which is difficult to appreciate in dogs, usually easier seen in cats. And with abducens nerve, there is a medial strabismus. Now, we can force eye movements by using the vestibular system's control over the eye position, known as the Dahl's eye reflex or the oculocephalic. This still involves cranial nerves 3, 4, and 6, and depending on the direction of the movement will depend on which nerve is involved. So recall that the oculocephalic is based on the movement of the head, creating an effective movement of fluid in the semicircular canals in relationship to the hair cells. And this movement or flow causes the hair cells to bend in one direction on one side of the head and the opposite direction on the other side of the head. That information is fed through the vestibular nerve. If the hair cells are bent medially, that causes excitation, and if they're bent laterally, that causes inhibition. And that is what the vestibular nuclei are going to use to detect the speed and direction of the head movement. So when the head moves to one side, the vestibular nuclei get excited and the other gets inhibited. The vestibular nuclei read that imbalance, send the information to 3, 4, and 6, which rotates the eye in the opposite directions at exactly the same speed. Now as the head keeps rotating, the eyes obviously don't spin around and go to the back of the head. So as they get towards one edge, the pontine nucleus reads that information and flicks the eyes quickly in the opposite direction to reset the eye location so the animal can fixate on something else. This reset is fast. The speed of the drift is based on the speed of the head movement, but the reset is always going to be fast. So we can force the patient to have these movements. If they're a small animal, you can just pick them up and move them side to side. Or if they're a larger animal, as shown in my other video, you can see that you can just move the head side to side and watch the eye movements. There should be a drift and a flick, a drift and a flick. This is the physiologic nystagmus. Now there can be spontaneous nystagmus, as this kind of movement should not be present when the animal is not moving. So with pathologic nystagmus, the brain is perceiving movement when none is there. This is often from damage to the middle ear altering the input. So if we wipe out the input from one side, the dog head reads that as if the head is being spun around, and a spontaneous nystagmus can develop in a spontaneous jerk movement of the eye. This tells us there's vestibular disease. Vestibular disease should have a slow phase and a fast phase, as opposed to cerebellar disease, where the movement can often be equal or oscillating. Another part to assess our neurologic exam is sensation to the face, movement of the face, and muscle mass. So here we're going to be looking at cranial nerves 5 and 7. The reflex to use is the palpebral reflex, and sometimes this is called, and sometimes we'll even do a corneal reflex. So with the palpebral reflex, we generally touch the medial canthus of the eye, which is the ophthalmic branch of cranial nerve 5. And this is also what's used for the corneal reflex as well. Whenever we're doing the palpebral reflex, the biggest thing that we're watching for is there going to be a blink? Now we need to also be watched to see, is the eye being pulled back into the socket, which in a normal dog is not going to be visualized. But if a dog has facial palsy, you can see that the sixth cranial nerve can still be working as it retracts the globe, and you might even see a partial blink because the globe is being retracted, but the lids are not actually moving. So that's something to be observant for when you're doing the palpebral. So 5 might be working and 7 not, but if 6 still is, you can get retraction of the globe. If cranial nerve 5 is not working at all, then there's not going to be either a palpebral or a retraction of the globe. Don't forget about the other branches of 5. So the maxillary branch covers the side of the face. The ophthalmic branch also does the inner philtrum of the nose. So in this picture, it's wrong. The nasal region should also be in purple. But the side of the face is the maxillary branch, and any normal animal should blink when you tap them on the face. So you should not have to pinch them to see if the maxillary branch is intact. The mandibular branch runs. So with the mandibular branch, it runs along the jaw. Now this area of the skin is not very sensitive and not very tender, so a lack of blinking on the mandibular branch is not a big concern. Really, the main important part of the mandibular branch is motor mastication. Is motor to the masticatory muscles. So generally, you will see muscle atrophy, or if there's bilateral mandibular branch involvement, you can actually see their mouth hanging open, as in this patient here. And then the patient on the lower picture, you can see that there's more severe muscle atrophy that's present. One of the few times where you'll see the actual mouth dropping is with trigeminal neuritis. If it's lateralized, the most common cause of that for the muscle atrophy is going to be a tumor, most commonly a peripheral nerve sheath tumor. Going back to the facial nerve, it supplies the muscles of facial expression. So with facial nerve palsy, dogs lose that fine muscle control to the face. Owners will often bring the dog in because the dog's not blinking on one side of the face, or they might even look funny and have a droopy face. You can see lips are drooping You can see the drooping lip in most breeds, and some breeds they have a hard time getting all the food into their mouth so they can get food stuck in the cheek because they can no longer move the lips to get it out of there. The ears can also be drooped on one side where the lesion is at, and for dogs that have erect ears, you'll see that that side cannot become erect. The whiskers on a cat should usually be upright, and they can be very active, especially in a new environment. But if you have a cat with facial palsy, it's going to be dropped on that one side. The nose being open too, especially with heavy breathing, is also innervated by the seventh cranial nerve. So with acute facial paralysis, everything on that side could be flaccid or droopy, but with time, those muscles can become contracted, as shown in this picture on the bottom left. The other thing that facial nerve is important for is the parasympathetic to the lacrimal glands. And so that's why if you have a patient with facial paralysis, it's very important to be sure to lubricate that eye because the lacrimal gland might not be working either. And there's also a little bit of sensory, so it's sensory to the inner pinna and also the rostral 2/3 of the tongue for taste. Now there is something called the atropine test where you put a little bit of atropine on the dog's tongue to see if they taste it, but this is usually not used. From cranial nerve 7, we go to 8, and 8 is the vestibular cochlear nerve. We talked about doll's eye and vestibular signs earlier, which is the main assessment for the vestibular aspect. For cochlear, more often than not, it is based on the history. Hearing, like vision, is a conscious perception, so we have to look for signs. Does the animal perceive sound? Animals can learn to pick up cues, so you have to make sure when assessing sound you are not in the visual field. As shown in this picture, you should be behind them when you're making a loud noise. Also, don't cause vibrations, as dogs learn to pick up vibrations as well as for certain cues. So if you drop something on the floor that causes vibrations, the animals might respond to it even though they didn't hear it. Also be careful when interpreting can the animal hear, because some animals just might not care if you're making a noise. Now there are electrophysiological tests that can be done, such as with the bear test, to know if the animal is truly deaf or not. Also, if a patient is unilaterally deaf, it can almost be impossible to know without advanced diagnostics. Last but not least is cranial nerves 9, 10, and 12, glossopharyngeal, vagus, and hypoglossal nerve. And they're all going to be part of the pharyngeal laryngeal function. Now, if we have glossopharyngeal and vagus, that's going to be the pharynx, larynx, and esophagus that can be affected. More often than not, the dog is going to be coming in with a problem because these are vital functions, breathing and swallowing. So this isn't something that you usually just pick up on examination. The owner's coming in with a complaint of it. So if there's a history of breathing or swallowing difficulties, then 9 and 10 problems should be on your radar. So if there's laryngeal paralysis, there's this inspiratory issue as shown on the image on the left. Again, something with 9 and 10 might come to your radar. With dysphagia, again, you can usually get something in the history associated with it. The voice can change, and if the esophagus is involved, you can get regurgitation as well versus vomiting. A swallow study with barium can be performed to confirm that a true abnormality exists. As far as with the reflex that we can use to evaluate this, it's going to be with the gag. So you open the patient's mouth, put your finger in an instrument in the back of the mouth, and watch for the gag to occur. The nice part about using your finger is that you can feel for atrophy and tone of the tongue, but obviously you can't do this on every patient. The tongue should always feel nice and meaty. Also, you can see if the patient actually feels it when you put your finger in the back of their throat. If you can put your finger all the way in the back of the throat, and the dog does not react, then I would be concerned that the patient might not be able to feel that region. Also, once the dog does the gag, observe what that dog does afterwards. They should look afterward or do a licking type motion, and you can see my dog do that in the video. So you can watch the tongue movement, and you can also see, does the dog swallow, because most dogs should. You can also feel the laryngeal region on the outside, so you can see the movement when the dog, or feel the movement when the dog swallows. Now, if an animal has hypoglossal paralysis, you can usually tell this by observation or with the history, so trouble with swallowing. If it's unilateral, sometimes they can compensate and might not have trouble swallowing, but the tongue will often deviate to one side, and over time, you can see the atrophy and contracture of the tongue itself. Now, you might have noticed that I skipped over the accessory nerve, and the reason for it is the clinical importance of it is quite small. It supplies the trap muscles of the neck and the trapezius muscle, but most owners won't notice if it is solely affected. There might be some mild voice change or change in swallowing, but it is of little functional significance. For the most part, 9 and 12 are going to live in the same region, and other clinical signs would be of more importance. But that's all I have for the examination. I hope you were able to make it to the end, and if you have questions, feel free to ask. Otherwise, I'll see you on clinic.